Having described the overview of anesthetic management, I will go into some interesting patients, some challenging problems which can happen during double lung transplantation. So here is, apart from RV failure, which I presented before, some other critical events has to be kept in mind. This is a patient with 35-year-old cystic fibrosis presented for double lung transplantation. Normal biventricular function, normal PA pressure to start with. So these typical patients can be done using an off-pump approach. So lung was implanted. There was some concern of RV dysfunction post-operatively, but we initiated some inotropes, inhaled nitric oxide, and the patient was transferred to ICU. And on post-operative day 1, the patient required increasing dose of inotropes. That is not usual for a patient who had normal pulmonary arterial pressure with a normal pulmonary vasculature pre-operatively. So here is, you can see, we were called in to do a TE. The TE shows, RV dysfunction, which is not usual with the patient who started cystic fibrosis, young patient. So you can see the dilated tricuspid annulus as kind of inflow-outflow view showing severe tricuspid regurgitation. What happened? So we took the patient back to the OR. So back in the OR, we are doing a complete comprehensive echo to find out what is happening. So you can see this is a kind of difficult view to see. What I am seeing here in this is the ascending aorta. This is the pulmonary artery. This is a kind of mid-esophageal ascending aortic short axis view, tilted the probe to the right. This is the SVC here. This is the right pulmonary artery. What you are seeing is a turbulent blood flow within the right pulmonary artery. You can see all kind of aliasing. There is what you want to see here after anastomosis is laminar blood flow. It is not always possible to use a Doppler to evaluate continuous wave Doppler or pulmonary pulse wave Doppler to evaluate for pulmonary artery gradients or pulmonary artery stenosis, because the placement of pulmonary artery is kind of horizontal. You can't really evaluate. But in this case, we could get a kind of tilted oblique view, and then we put a continuous wave Doppler across the anastomosis, and you can see the peak gradient was 50. The peak gradient should not be 50 in any kind of pulmonary vasculature. Usually the peak gradient is less than 5 to 25. So you are seeing something like 50, which is more than mild. There is no real gradients to diagnose mild, moderate, severe pulmonary artery stenosis. You are kind of extrapolating the pulmonary valve stenosis to the pulmonary artery stenosis. So if you have more than 25 of gradient, that's pretty significant for a pulmonary vasculature. So that's what we found here. So you have some obstruction in the pulmonary vasculature, which may be there before, which was not diagnosed intraoperatively when they did the first lung implantation, or it is possible something developed post-operatively. So the surgeon explored the pulmonary vasculature and then found a lot of lymph nodes around the pulmonary vasculature, including the anastomotic part. So he released all the lymph nodes. The cystic fibrosis patient has a long-standing infection, and they can have a lot of lymph nodes in the chest, and it can. That is what happened in this patient. So it was released.